be speaking on topic of complex intra-articular fractures of distal end radius and the column concept. So I have no relevant conflicts or disclosures regarding this presentation. The scope of talk will be on introduction of distal radius fractures, to recognize fracture patterns and identify those that require fixation, to understand the column concept of distal radius fractures and how to apply it, different approaches used in fixation of distal radius fractures, and caveats in the management of distal radius fractures. So the distal radius fractures, everyone is an expert in distal radius fracture management. It's fixed by every orthopedic as well as hand surgeon. Everyone thinks that they can do it better than the surgeon next door. And every surgeon shares their success and triumphs, whereas hide their failures. So distal radius fractures, they account for almost 15% of all fractures. It has bimodal incidence commonly seen in pediatric age group and old age group. A disagreement exists regarding the optimal management of distal radius fractures among most of the surgeons. If we go into 19th century, Sir Abraham Coles described distal radius fractures as once the fracture consolidates, the patient enjoys pain-free complete range of movement. It's just that the deformity will be persistent. But this doesn't hold true in today's era, where we see most of the distal end radius fractures after high velocity motor vehicle accidents, then adventure sports injuries. The treatment of distal radius fractures has evolved significantly. It started with close reduction plaster application, then moved on to close reduction K-wiring with sometimes external fixator application, then came in plates, and recently we are also able to see the micronails used in intramedullary fixations for distal radius fractures. Whatever treatment modality we use, the goals of distal radius fracture management is to restore normal anatomical relationship as and when possible, to maintain this fracture reduction until the fracture unites and consolidates, so that the patient enjoys restoration of normal function and good range of motion with minimal complications of tendon and nerve injuries, scar, and stiffness. There are different factors which determine the treatment options. First is fracture characteristics, whether the fracture is open or compound, whether it's a simple or comminuted fracture, whether it is an intra-articular or extra-articular fractures. Second is patient factors. Is patient having any comorbidities? Is he or she osteoporotic? Are there any cost constraints? And lastly, surgeon preference as per his understanding of the fracture and the locally available implants. So whenever a patient of distal radius fracture comes, it's of utmost importance to understand the unstable fracture patterns and fractures that require fixation. LaFontaine and colleagues have came up with paper in which they describe the instability risk factors. They came up with 6 such factors. First is comminution, dorsal angulation of 20 degrees or more, intra-articular involvement, ulnar fractures, presence of ulnar radial shortening of 5 mm or more, or severe osteoporosis. If there are 3 or more factors present, then the fracture is amenable for operative intervention. La Martina in 2015 published a paper where they describe hook sign. They say that restoring volar cortical continuity by hooking the volar cortex in the initial reduction is the strongest predictor of the final volar tilt and carpal malalignment at the union. The recent AAOS guidelines of 2022 mention that in young active individuals, operative treatment is recommended for radial shortening of more than 3 mm, a dorsal tilt of more than 10 degrees, and intra-articular displacement or step-off of more than 2 mm. Non-operative as well as operative treatment outcomes are same in low-demand patients. There are different classification systems, as many as 15 described in literature. The commonly used are eponymous such as Smith, Barton, Schoffer, Gartland and Worley, Frickman, Fernandez, Ao, and Millen. But no matter which classification system we use, there is an the intra-observer reproducibility as well as the inter-observer reliability ranges from fair to poor. As a result, it is very important that this is the reason that there are no specific guidelines regarding management of distal radius fractures as of now. We feel that the column concept comes in handy in distal radius fracture. It was described by Reichle and Regazzoni, and this forms the basis of fragment-specific fixation as described by Geisler and Fernandez and else in management of distal radius fractures. So in column concept, basically the wrist is divided into 4 columns. The first is the radial column, the intermediate column, the ulnar column, and lastly the pedestal column. These columns are further divided into different fragments. The radial column consists of radial styloid fragment. The intermediate column consists of dorsal wall fragment, volar rim fragment, the dorsal ulnar and volar corner, the free intra-articular piece, then the metaphyseal defects that are seen. And lastly, the ulnar column consists of ulnar head fractures and ulnar styloid fractures. It's very easy for one to identify these different fragments, and they help us to decide the fixation that we are able to use in fixation in distal radius fractures. The concept of fragment-specific fixation is that we should achieve a stable fixation of all columns and its components. We should start with the simplest techniques such as buttress plating, and sometimes we might even need to use advanced techniques such as spring plate as and when to address fixation of all fragments. These are few examples where in first picture on the left you can see that a volar ulnar fragment is fixed with a simple buttress plate, whereas in second picture we can see that volar rim fracture which is fixed with a spring plate, and the radial column fracture is fixed with buttress radial column plate. For dorsal column fixation, the fixation is many times in the buttress mode after elevation of the articular surface. The algorithm for fragment-specific fixation in distal radius fracture begins with volar rim fragment assessment. Whenever possible, we should use volar locking plate for fixation. Then we should divert our attention to the dorsal ulnar corner at dorsal wall fragment. And then we should fix the radial column either with the help of lateral column plate or K-wires. Lastly, when all fixation is done, we should assess the stability of DRUJ and repair TFCC if gross instability exists. This is a video of volar approach of distal radius fracture. We begin with, just a moment. So we begin with the volar incision over the FCR. An angle is created at the distal extent. The FCR tendon is identified and retracted laterally. We go through the subsheath of FCR and identify the FPL tendon. The FPL tendon along with PL and median nerve is retracted medially so that we are able to see the pronator quadratus and the volar capsule. The pronator quadratus is then released with sharp dissection, making sure that the fascia is intact. This helps in closure of pronator quadratus at the end of the surgery. So here we can see that the pronator quadratus is elevated sharply, and after that we are able to see the fracture underneath. The second approach that we used is the volar ulnar corner approach. It is basically used for the volar ulnar fragment fixation, isolated volar ulnar fragment fixation. In this, the exposure is between the FCU tendon medially and the PL, FDS and FDP tendons laterally. We begin with the skin incision, which is similar to the extended carpal tunnel approach. The skin and subcutaneous tissue is cut, and the FCU tendon is retracted medially while FDS, FDP are retracted laterally. The pronator quadratus is identified and a tunnel is created underneath the pronator quadratus. Once we tunnel it, then we are able to see the fracture fragment, as we can see here. After the fracture fragment is seen, then we are able to fix it with the help of hook plate by Arthrex. We use K-wires to create tunnel in the bone, and the hook plate is then hammered, the distal end of hook plate is hammered in, and the proximal part is fixed with the help of screws. A good alignment of fracture is confirmed on lateral as well as PA view. The third approach that we used is the dorsal approach. It is basically for the dorsal extensively comminuted fractures with very minimal volar involvement. In dorsal approach, we take a linear incision along the Lister's tubercle along around 6 to 8 centimeters. After elevating skin flaps, we identify the EPL tendon. The EPL tendon it acts as a lighthouse for this exposure. The extensor retinaculum is cut in the roof of EPL tendon. The radial column is approached by sharp dissection of first and second compartment, and the ulnar and the intermediate column is approached with the sharp dissection of the fourth extensor compartment. After this, the intra-articular fragment is elevated and we fix with the help of two plates. Now, on the volar side, one must remember that there is a transverse ridge called as watershed line. It is at the distal extent of pronator quadratus. The routine volar plates that we use should be fixed proximal to this watershed line to prevent any irritation of flexor tendon. Now some tips and tricks for reduction of distal radius fractures. First, for the reduction of the radial column fracture, one should identify the brachioradialis tendon. It is the flat tendon on the lateral aspect. We are able to identify the first extensor compartment tendons as they are more tubular. Then we release the attachment of brachioradialis at the radial styloid, as shown here. This helps in achieving good reduction of the lateral column. Second, sometimes whenever there are rim fractures of the volar side, it is difficult to identify them and they are often missed. So we propose that we can elevate this volar capsular flap which extends from the watershed line, and distally it extends up to the joint line. We elevate this with sharp dissection. After elevation of this flap, then we are able to see the volar rim fractures more clearly. This is the flap, volar capsular flap. After elevation, we are able to see the volar rim fragment more clearly. If we use routine plates like this, we will miss the buttressing effect for the fracture fixation, and as a result, there will be failure of fixation. So for this, new special design plates are available called as rim plates. They have an anterior bow which kind of hugs the volar rim. Now some examples of this distal radius fracture fixation. We can see that on PA and lateral view, there is a lot of radial shortening, comminution, as well as the dorsal angulation is almost like 40 degrees with dorsal subluxation. So this comes under unstable fracture pattern, which requires fixation. When a CT scan is done, we are able to see multiple fragments. The radial styloid fragment is separate. There is a depression of the intra-articular fragment, as well as lot of comminution of the dorsal wall. So fixation begins with the volar approach. We first address the volar rim fragment with the volar locking plate. At the same time, the lateral column is temporarily stabilized with the help of K-wire. After that, we move to the dorsal approach. We elevate the intra-articular fragment, and we need to stuff in bone graft to prevent any delayed collapse during movement. This is the Siam picture, which shows 3 plates: the lateral column plate, the volar locking plate, and the dorsal buttress plate. Second example is a 20-year-old boy with a history of road traffic accident. The PA and lateral view, we can see that the DIUJ joint space is slightly widened, which pointed us to take an oblique view. And on taking oblique view, we are able to see a separate dorsal ulnar corner fragment. The same thing got confirmed when CT scan was done. So this fracture was approached with fixation of the volar side first, and followed by dorsal approach for fixation of dorsal ulnar corner. The fixation of dorsal ulnar corner is very important, as it will help us to recreate the alignment in sigmoid notch, allowing full pronosupination movement in future. This is third example, a case referred to us. This was the initial picture, the PA and lateral view. We can see extensive comminution of the metaphyseal area, along with multiple fragments of lateral column, ulnar intermediate column as well. This was the fixation that was done by primary surgeon, where he used a locking plate which was supposed to end at watershed line, but it went on to extend till the rim fragment, and there was no buttress on the dorsal side. As a result, this fixation underwent failure. When he came to us, we got a CT scan, and we were able to see that there were also some screws intra-articular, along with multiple fragmentation of the fragments. We went in, at first we did an implant removal. In implant removal, we are able to see that as the plate was extending right up to the volar rim, it resulted in fragmentation of it resulted in some synovitis change of the FPL tendon, which sometimes later on might undergo attractional rupture as well. Then an arthroscopy was done to look for the articular surface. If at all since the articular cartilage was found to be good, we proceeded with the fixation. The plan was, if articular cartilage was not good, we were going to proceed with partial wrist fusion. Here we can see that there is just some step in the articular surface. Otherwise, the cartilage looks quite good. So we proceeded with fixation. We started with the volar side first, got the volar rim fragment aligned along with the lateral column fragment. Then we proceeded from the dorsal side, elevated all the articular surface, stuff in bone graft, and dorsal buttress plating was done. This is the 6 months follow-up X-ray along with clinical photos of range of movement. And the patient has got almost full flexion extension, as well as the pronosupination is full. He has returned to his activities as before injury. We have published a paper where we have mentioned the reasons for failure of distal radius fractures. I suggest you can go through this paper for further details. So in summary, the distal fractures will continue to challenge us. Understanding of our failures of fixation can improve our future success. Careful assessment of fracture can determine what optimal fixation should be done. Each fracture is unique and should be treated as such. It is surgeon and his and her understanding of the fracture of how to fix it and not the hardware that makes the outcome impossible. Thank you.